Hi everyone, I am Dr. Buvaneswari. I am a medical director of GBR Fertility Centre and Hospitals, and also we have a Institute of Reproductive Medicine at Dr. Rela Institute and Medical Centre in Cropate, Chennai. So today I am going to discuss regarding poor ovarian response. We are seeing more and more nowadays people having a less number of oocytes, that is less number of eggs, and again the success is going down because of the less number of eggs, or some people they not even having a few oocytes, one or two also we are not able to get it. So what is the reason for this? One is that late marriages and advanced age, and sometimes because of autoimmune causes, genetic disorders. Sometimes we repeat surgeries. They would have undergone repeated surgeries like endometriotic surgeries where ovarian tissue is lost. Some people have gone for any cancer therapy, and these are the situations we are seeing. But there are some conditions we are seeing even at younger age, around 30-32 years, patients having very poor response. In spite of us giving higher dose of injections, we are not able to get even one or two oocytes. So when do you call it as poor ovarian reserve or response? Because when you have less than 5, that is the cutoff. In every studies they have proven that when the woman has less than 5 follicles or 5 oocytes, then they are considered as a poor responder. Again, their AMH level, if it is less than 1.2, if their FSH level is more than 10, if they have a less number of oocytes on the day 2, less number of follicles, antral follicle, that is what we call it as baseline follicular count is very less than 5, and these are the patients we will be terming them as poor responders or poor people with poor ovarian reserve. Those situations, what do? We have to first of all rule out any genetic disorder. If they are aged, definitely we have to consider it's a biological phenomena. But if they are young and poor ovarian reserve, then we have to rule out definitely premature ovarian failure or poor ovarian insufficiency due to any genetic disorder like Turner syndrome or some other chromosomal problems. So once we do that ruling out, then we have to consider treating them with some adjuvants like androgen, like testosterone medicines, some injectables what we will be giving for them to increase the ovarian reserve. All these medicines like tablets or gel forms or injections only to a certain extent we can give, and they will improve the ovarian reserve. They will only increase the number, not the quality. There are few papers which they are saying that by doing some regeneration methods like ovarian tissue injection of platelet PRP, or when we derive bone marrow derived stem cells are injected into the ovarian tissue or into the ovarian artery, they say that there is some amount of improvement is there. But these are all experimental studies and only very few number of cases are reported. We have to only try on those patients who are genetically normal, who are young, or won't have only their own biological child, and when they have very less ovaries or very less oocytes or only one or two eggs. So those situations we have to consider them for any newer technique, which even though it is an experimental or this is only having a small study evidence. And next, what do we do? These patients, when we do counseling, we have to properly counsel for the type of treatment, higher dose of injections, and again different types of protocols. So to get the maximum number of eggs, as I said, we will be using some adjuvants like some medications before starting the IV program. During the program, again we will be doing a different kind of protocol where we use higher dose of medications and different kind of protocols. At the same time, we also do, there is a new protocol called dual stimulation. This is what I am going to explain here. These patients, when we stimulate per cycle, it will be like 1 or 2 eggs. So again we have to wait for the another cycle, then take 1 or 2 cycles like oocyte pooling. Already I would have said in many videos, when they have very poor ovarian reserve, we will be doing multiple cycles to have a pooling of oocytes and then ICSI. Then we do a good embryo transfer after that. But what happens, instead of wasting time, and there are patients who are in the elderly age group we don't have much time. Instead of doing that, we can do in the same cycle dual stimulation, double stimulation. We'll start with your cycle, do injections, and then egg pickup will be done. Do IVF and keep some embryos. Then give 3-4 break. Then again we restart the stimulation like that. By doing these methods, we can get in the same cycle instead of 2 follicles, 4 or 5 follicles and 5 oocytes is possible. That is what most of the studies have said. So we will be doing this newer technique called dual stimulation to get maximum number of eggs. Once we get it, we do ICSI and then we will freeze the embryos. Once we freeze the embryos, again before freezing, to know that whether they are good quality embryos or not, for these patients it is justified to do a PGS or PGT if they have any genetic disorder. If they don't have, just because of the poor ovarian reserve and only having few number of oocytes, we want to be sure about the euploidy rate, we will be doing PGS or PGT depending on the requirement. Further, why do we do that? When the patients are very young, around 30 years, we know that their euploidy healthy embryos risk is that around 60% of the time their embryos will be alright. If you are above 35 to 40 years, then your healthy embryo risk, like that is the high risk of abnormality is there, chromosomal abnormality is there. Only 30% of the time we will be having a good quality healthy embryos. At the same time, if you are more than 42, 43 years and all, your chances of having a good quality embryo is only 10 to 20%. That is where we are saying that more than 80% of the embryos will be very abnormal. So we cannot transfer those embryos without knowing their potential. That is the reason it is an optional. So we have to, if you are already gone through many cycles and you are in the age of around 35 plus and you already have only very few embryos, we might itself do a PGD or PGS to know the healthiness of the embryo, and then you can get the embryo transfer. This way you have a higher chances for pregnancy. Same time, we have to also make sure that your uterine side also is everything is perfect. Once the embryos are good, then your uterine side also we have to focus. Make sure that your uterus has a good receptivity, good blood flow, and there is no fibroids, no polyps, no adenomyosis, and everything should be ruled out. Then if you do the PGS or PGT and have a good healthy embryos, the chances for pregnancy at any age group is very good. That is what all the comparative studies are saying. Because age is the main predictor of the pregnancy outcome. So this poor pregnancy poor ovarian reserve is always a limiting factor for any success in the treatments of infertility. So we need to focus selection of the proper protocols and the selection of the embryos by morphologically and by seeing the good quality embryo, using some technology, that is different aspect. At the same time, we have to see genetically or chromosomally the embryos are good or not by doing some pre-genetic diagnosis. So these are the gist of the treatment protocols what we use at our IVF center. We generally do a proper analysis of the patients. We give them a once they are diagnosed as poor ovarian reserve people, we do proper counseling. We give them a 3 months of medications to improve their ovarian reserve or any technology which can improve them depending on their indications, either regenerative therapy or medical therapy, and then we will program them with dual stimulation and pooling of oocytes will be done. And in case if there is any suspicion of a chromosomal or genetical abnormality, we do pre-genetic screening of the embryos and then we freeze the embryos and transfer the good quality embryos. So that is why we will be able to give a good success in the cases of very elderly age group or people who have a poor ovarian reserve. I hope this is very useful to you, and you can share and you can comment about this, and you can share this video to your friends and family who are having a fertility issues. And if you have any queries, you can call our helpline, and anyway you can come on online consultation also for your further queries or questions. Thank you.